Good afternoon, everyone, and thanks for joining us for this Healthline 3, where we like to focus on ways to improve your life or the lives of those people that you care about. And we're joined today by a very special guest, Dr. Rick Stafford, and we're focusing over the next half hour on atrial fibrillation. Yes.
Atrial fibrillation.
And you can call 318-219-4569. Please call and ask your questions during the show. You can speak directly with the doctor and get your questions answered. So, first of all, tell us what an interventional cardiologist actually is.
Interventional cardiologist is one who it's related to cath lab procedures. Patients who have blockages, most cardiologists do diagnostic catheterizations where they take pictures, but interventionalists, they fix them with balloon angioplasty and stents and some devices called atherectomy that remove some of the plaque, but it's restoring blood flow to the narrowed vessels due to atherosclerosis or plaque.
So is it really a specialty in cardiology, or what?
It is. It's it used to be an additional year. Now some places an additional 2 years of training. But there are some, and there's actually a separate board certification and things like that for interventionalists, just like there are for electrophysiologists, the heart electricians.
All right. So you're well trained, is what you're telling us.
That's correct.
Okay. Well, we're so excited to have you here today.
It's good to be here.
To talk about atrial fibrillation. Let's start with the basics of what exactly is it?
Yeah, atrial fibrillation is it's an irregular heartbeat. It's relatively common, in which the heart beats very fast. Most cases it's not a life-threatening heart problem or a rhythm disturbance, but the biggest thing is the stroke risk is much higher, as much as 5 times higher than people that don't have atrial fibrillation. And
translate that into real numbers for me. And when you say the stroke risk is 5 times higher, how likely is that?
And it's fairly high. There are some, I think 1 in every 6 to 7 strokes is related to atrial fibrillation, so that's very common. Atrial fibrillation is 5-6 million people in the United States have it. 500,000 cases, hospitalizations a year related to atrial fibrillation. Some people are more likely to get it. There are some risk factors for atrial fibrillation that include age over 65, other forms of heart disease, high blood pressure, alcohol use, diabetes, valve disease, some lung diseases, obstructive sleep apnea, COPD, things like that. I'm sure I'm missing some, but there are quite a few things that make you at higher risk.
At higher risk. And so I associate that with aging. So you mentioned over 65. So
That's
atrial
correct.
fibrillation then is not really something you would see in a 14-year-old or a 22-year-old?
It's uncommon, but you do see it. I mean, I've seen people, maybe a half dozen every year or so, that are in their 20s and 30s that have atrial fibrillation, but it is mostly something in an aging population.
So is it ever just a genetic heart defect?
It's generally not. There are trends that seem to run in families, but it's not something that's generally inherited.
So men and women, do they both get it? When I think of heart problems, I often think of men as more likely to have heart issues. And of course, we know women are protected, if I'm correct, from estrogen until menopause, and then their risk increases as
usually
well.
There's about a 10-year lag there. But with atrial fibrillation, the incidence with men and women is really about the same. But as far as overall stroke risk, women are more likely to have strokes than men.
Women are more likely to have
That's
strokes.
correct.
Okay, why don't you give us the definition of a stroke so we can be sure that all of our viewers fully understand what a stroke is. And how is it different from a heart attack?
And some strokes are very similar. There are what we call ischemic strokes that are due to what we call atherosclerosis or plaque formation that narrows a blood vessel and reduces the blood flow to the brain. Just like a narrowed blood vessel reduces blood flow to the heart muscle and causes chest pain or angina, and also causes heart attacks.
So why is it that atrial fibrillation actually makes you kind of go through, take me through the body, more likely to have a stroke?
And those strokes are a little bit different. Those are what we call embolic, and that's a clot or something that enters the bloodstream that can travel and lodge somewhere that you don't want it to. And with a normal heartbeat in someone that's not in atrial fibrillation, the top chambers are atria and the ventricles, the bottom chamber, they kind of work in harmony to provide blood flow. But with atrial fibrillation, you get stagnant, blood flow that can be a kind of a precursor to clots that form. And those clots can break loose and travel in the bloodstream and go to the brain and cause strokes.
So what does I've been telling you we're debuting our new set today. We're so excited about having our newscast downstairs, and I can tell you with great certainty you're going to have a lot of racing hearts out there and behind the scenes. How does one differentiate from a racing heartbeat because you're nervous and excited versus atrial fibrillation? How does it feel different?
And sometimes it doesn't, but most of the time with atrial fibrillation, people feel skipping, fluttering, heart racing. Sometimes it could be hard to differentiate, just some anxiety or nervousness and the heart racing, dizziness, lightheadedness, those types of things. Probably less common, chest pain, passing out, heart failure type symptoms.
Well, I mean, those are pretty obvious. So could someone not pick up on, is it fairly easy not to pick up on atrial fibrillation? Because you
can. Most of the time, in most people, it's a fast rhythm, and most physicians, just all physicians, should be able to just put a stethoscope on the heart and be able to, most atrial fibrillation you can tell. It's very irregular, generally very fast, not always, but it's usually fast.
And aside from having a fast heartbeat, and I'm referencing a friend of mine who had it. Aside from the fast heartbeat, how do you generally feel when you've got that over a sustained period of time?
Sometimes it's just the symptoms that I mentioned first, the racing heart, shortness of breath, fatigue, those types of things. But the fatigue is certainly significant. Some people can't tell when their heart's racing. One person might have atrial fibrillation, 6-8 beats, and they feel every single beat. It makes them feel terrible. They get nervous, dizzy, lightheaded. Other people can be in it for a long period of time and never know it. I've had people come into the office just saying, you know what, doc, last couple of weeks I've just felt kind of tired. I feel like something's up, and do an EKG and they're in atrial fibrillation, 160 beats a minute, and they had no clue.
So when you are in atrial fibrillation, I mean, I think about when you're doing a lot of exercise, does it feel like you're just constantly running or something like that? Is that kind of that in the, I think about the fatigue I feel after getting my heart rate up for an extended period of time. Is the fatigue that you feel from that similar to atrial fibrillation? It
is, and everyone's different, but that's very common is to have fatigue from, it's like being on a treadmill for extended periods of time, so it just wears you out.
When it comes to heart problems, I think most of us get pretty scared when a relative says,
sure.
I've got a heart problem versus I've got a leg problem or something like that. Do you find you have a lot of patients who come in and are pretty terrified by how they feel?
We do. Some come in, downplay the symptoms, and while others can have what we might consider relatively mild symptoms and have.
Mm-hmm. So how do you know for sure when you need to go in and get checked out? And the other question I have is, do you start with your primary care doctor and usually get a referral, or do people go straight to you?
Some people go straight to us. Some people that are already established with a cardiologist, I think that's fine. Some people call our office all the time to make appointments, but most of the time a primary care physician can diagnose that. A lot of people diagnose it themselves at home.
Mm-hmm.
I felt funny last night. My wife checked my blood pressure. It was normal, but it said my heart rate was irregular, and the rate was 125 beats a minute, and that usually sends up red flags, and they get on the phone and call their physician.
All right.
Smartwatches and Fitbits and things like that.
I had not thought about all of those devices. So we have a caller right now. Sandra, welcome to the show. Please ask your question.
Thank you. I would like to ask the doctor, pre-COVID, I never had a problem with my heart, but after COVID, I am experiencing some really rapid heartbeats. But it's not all the time, it's just on occasion.
How long ago did you have COVID?
2 years ago.
2 years ago. COVID is kind of a difficult thing to figure out sometimes. We see all kinds of cardiac issues that are much more likely, seem to be more prevalent in the COVID era. The things that you worry about the most, the cardiomyopathies and myocarditis, we're actually not seeing too much of that, but a lot of people like yourself that have continued or persistent shortness of breath or your heart racing, skipping, fluttering, tachycardia, and it's a difficult problem.
I want to talk for a minute about COVID and share the experience of a friend who will remain nameless. He went and got a COVID vaccine, next day thrown into AFib. And I remember coming across an article in a major publication based on journal study that some people, when they got the vaccine, did suffer that. Did you see people in your practice who did? And for those individuals who did, what should they do when it comes to that second and third and fourth vaccine?
I think it's hard to determine if the symptoms are related directly to the vaccine itself, and probably most of the problems probably are not. But like any vaccines, like a flu vaccine, COVID is the same. It's you can have flu-like symptoms and fever and chills, and any of those types of things can make you more likely to have some type of rhythm disturbance, including atrial fibrillation. And so there's no way to really determine if that's going to occur on subsequent vaccinations. There's so many people, I got the first shot, I feel terrible. Second and third, I did fine.
So generally, your recommendation would be don't fail to get the vaccine in the future because you had that experience.
That's
and
correct.
The timing was
Absolutely.
Close and suspect.
Yeah, absolutely.
Now we've only been in COVID now for a few years, and of course we're kind of coming out of it.
Hopefully.
But do you think we're going to find 5-10 years from now some additional long-term effects from COVID? And in fact, the heart and AFib may be one of them, just kind of that permanent damage that doesn't really emerge until we age.
I think it's a possibility. I think it's really too early to tell right now. I think this is, the vaccines had to come out in a very short period of time with a lot of research in a short period of time to come out with those. So I think it's difficult to really tell. I think 5 years, 10 years will give us a lot of information and, a lot more patients in clinical trials that'll be able to answer some of those questions.
So somebody comes in, they clearly have and by the way, when we talk about a fast heart rate, what are those magic numbers?
It's what's considered tachycardia is anything over 100 beats per minute. And a textbook range for a normal, kind of a range for rhythm is 60 to 100, but probably 55 to 85 is really a better range. If you're used to a heart rate that's in the 60s and 70s and all of a sudden you're 90, 95, even though it's technically not tachycardia, you probably feel pretty lousy.
And when someone comes in and you determine that they do in fact have a problem, what are the different roads that you might take with respect to their treatment?
The treatment?
What are the various treatments and who gets what?
I think with atrial fibrillation, treatment is kind of a stepwise type path. First of all, it's
There you go.
the first line of treatment is typically medications that slow the heart rate. And those are typically classes called beta blockers or calcium channel blockers. There's older medicine called digoxin that we still use. Some people just slowing the heart rate, that seems to take care of their problems. We call that rate control. The second tier is something that we refer to as rhythm control, and that's where we make efforts to get them back into the normal rhythm. And that can be done sometimes with more potent antiarrhythmic medications, and sometimes that requires shocking the heart back in normal rhythm. Some people require multiple medications or even stronger medicines. That's probably the third tier. And there are some people that we recommend procedures. Or I think I said earlier, there's a specialist called an electrophysiologist in cardiology, and they do ablations of various types of rhythm disturbances, including atrial fibrillation. Some of those are with heat energy from and some of them are cryoablations with things that freeze abnormal pathways and abnormal tissue that's causing rhythm disturbances.
And when you talk about the shock and the heart, we can't help but think about the incident that happened on the football field this week. And as a result of that, many have talked about what we have in workplaces and various venues, especially large venues, so that people on site are able to do some of this. What can an untrained person do to help somebody who seems to have some kind of distress, either from atrial fibrillation or a heart attack or something? What do you recommend that individuals and workplaces plan for?
Yeah, I think having a way to check blood pressure is always helpful. I think workplaces, if it's a small 3 or 4 employees, then defibrillators, the automated defibrillators that are probably pretty expensive for a small group. But I think any large businesses, I think that's a good thing to have. I've been to hunting clubs that have AEDs on the walls, and I think those are for more life-threatening rhythm problems, like the football player had on the field. Atrial fibrillation is a little bit different. It's more likely to cause symptoms that can make you feel bad, but generally not life-threatening like that. But I think in the workplace, I think we're seeing all these automatic defibrillators that are very easy to operate. You open the container that they're in on the wall, and they have very easy cookbook type instructions, and those actually will tell you if it's a heart rhythm that needs to be addressed or might need a shock.
I'd be terrified to pull one of those out and try to use them on people. Generally, do you recommend training? Kind of like what we have in an airplane when they say, all right, if this happens, you do this, X, Y, and Z. I would imagine just having those in a workplace you'd find people a little scared to pull it out and use it.
Yeah, I think just with just minimal training, I think anytime that one of those is put into place, then probably 15-30 minutes of kind of going over it and with using some people as models to try determine how to put them on, but they're actually quite easy and really self-explanatory.
All right, and we have a caller right now. I believe, is it Glenda? Is that correct?
Yes, it is.
Please give us your question for our doctor.
Doctor, I was diagnosed with AFib in 2010, and all they've ever done, I've had some, where they stop your heart and restart it and all that.
Yeah, the cardioversion.
But they just recommend a blood thinner. Is that correct? And I've had no problems.
Yeah, there are in a lot of people that have atrial fibrillation because of that stroke risk. The blood thinners are, of course, what prevents the strokes, and not everybody has to take a blood thinner, but most of the time if you have other medical problems, then blood thinners are necessary. Some people, the rate is okay, but a lot of people require other medications to try to keep you in the normal rhythm.
Would you think that because I've had it since 2010 and had no more problems much, that's the correct thing to take, the blood thinner?
Oh, absolutely. That's by far the most important thing.
Listen, thank you so much.
Oh, certainly. It's my pleasure.
Yes. Thank you for calling. We appreciate your call and your questions, and we certainly hope other people will call too. The number on the screen is 318-219-4569. So please do call and ask Dr. Stafford your questions. So she got me thinking when as she mentioned that she had this 10 years ago. Is atrial fibrillation something that when it's addressed, it can be managed and you can live a long, productive, and happy life?
Absolutely, and that's variable as well. Some people have atrial fibrillation, have an episode, whether it goes back to the normal rhythm on its own, or requires medications or shock procedures, and then they never have a problem for many years. And some people have, once they have that first episode, they seem to have ongoing problems. So it varies greatly.
Do people who suffer from this, are they often afraid to go very far from their doctor or travel or get out because they're afraid of an incident? Do you ever see that?
That can happen. Yeah, we see that with all kinds of rhythm problems. And I think when it comes to that, if you've been tried on various medications and you still have symptoms, and that's certainly the people that probably need more specialty type treatment, ablation, consideration of ablations if they're candidates for that.
So let's talk about the different signs for, we've talked about AFib signs, and signs for a heart attack. One of the things that's always intrigued me is that we know what a heart attack is supposed to look like with the man. I mean, we've had the men on TV grab their chest, and and for years we thought that it would portray itself the same way in women, and then we started doing more research and we realized women, when they suffer a heart attack, their symptoms are often very different.
Yeah, it certainly can be. Certainly the classic symptoms that you see, the squeezing in my chest, an elephant on my chest, shortness of breath, breakout in a sweat, goes to your left arm or up to your neck, jaw, those types of things. Not everybody has that, and women still are more likely to have more classical symptoms, but they're also have commonly can have atypical symptoms. Sometimes just fatigue. It could be right arm. It can be just dizziness. Presents in a lot of ways. Nausea sometimes, and go to quick care, go to some other facility and get medicine for nausea, and sometimes there's nothing sticks out to really do more testing sometimes.
Yeah.
And we get fooled all the time.
Yeah. And a lot of people don't want to find out that they have that kind of problem.
Absolutely.
All right, so we have another caller, I believe. Pat, is that correct?
Yes.
Okay. Please ask your question of the doctor.
I just had a little episode, and they said I had AFib, but by the time I went to the cardiologist, a few hours later, it had righted itself. They're going to do some more testing on it, but I was wondering whether I had COVID on Thanksgiving week, and I was wondering if that could have been a precursor to the AFib.
Could have been. We see all kinds of electrical problems with the heart, and a kind of a wide variety of heart problems that occur related to COVID. Atrial fibrillation is so common, it's almost impossible to tell. Was it related to the COVID? Was it related to a vaccine? But certainly can be. I know that doesn't give you a specific answer, but it certainly can be.
So how are you doing today? Are you doing better?
I am. Also found out I had high, I can't even think of the word now. But, so I'm having some more tests next Friday at the cardiologist.
That's good.
Okay. Well, we wish you all the best with that appointment.
Thank you so much.
Oh, thank you.
But with triggers, like she's asking about COVID, the triggers that we see for atrial fibrillation, high blood pressure, high cholesterol, heavy alcohol, diabetes, obesity, all those things, caffeine, over-the-counter decongestants can be culprits, lung disease, sleep apnea, any kind of infection or especially respiratory problems. We see it all the time after surgery. Lots of different things can trigger it.
All right, so okay, we have another caller. I believe the name is Lonnie. Welcome to the show. What's your question for us?
Yes, ma'am. I just went to the emergency room with the flu and found out I had COPD and AFib. Now, they put me on this medicine. It's Eliquis. That's a blood thinner. But I was already taking baby aspirin. That's a blood thinner, too, isn't it? Should I still keep taking that baby aspirin? I forgot to ask my doctor that. That's my question there.
Usually, aspirin it's an important medicine that helps prevent heart attacks and helps prevent some types of strokes, especially the strokes that are related to plaque. Aspirin doesn't really have any role in stroke prevention with atrial fibrillation, which is due to a clot that forms and travels. And so the other blood thinners or anticoagulants are the ones that are important for that. And that's Eliquis, Xarelto, Pradaxa. Those are newer agents that we call direct or novel oral anticoagulants. And then the old ones are Coumadin or warfarin. But those are the ones that are important for stroke prevention. And as far as the question, should you take both? Kind of depends on if somebody's had other forms of heart disease or other reasons to take aspirin. Then we frequently have people take aspirin and these other blood thinners, because aspirin works on your platelets where the others act on clotting factors, and a good bit different.
So do you ever give people who have AFib a pacemaker? Are those two things, do they ever go together?
They do. Pacemakers most of the time with atrial fibrillation are reserved for people that have heart rates that are very, very difficult to control. Some patients, you start on a low dose of a beta blocker and their heart rate drops and they feel fine, they do well. Other people, you have them on 2 medicines, 3 medicines, you've maxed them out. And now you're trying to do everything you can to slow the heart rate down, but most of those medicines also lower the blood pressure. And so then they feel lousy. Their blood pressure is down, and the side effects to these multiple medicines at higher doses. And so those people, there's a different type of ablation than the kind I mentioned earlier. And this one is this is called an AV node ablation. But that's where you interrupt the electrical system between the top and the bottom chambers. And after you do that, you're dependent on a pacemaker for the pumping of your heart that pumps the ventricle, the bottom chamber.
Gotcha. Okay,
It's a little different.
We have another caller.
Okay.
We're getting lots of callers
That's
today.
good.
You've got some good information here. Ashley, please ask us your question.
Hey, my question is, I have an Apple Watch, and it often notifies me that I'm in AFib, but I've had workup with my primary care, and in fact, I'm not. Do you know why it keeps giving me that error?
We get those questions every week, probably 2 or 3 people every week.
Wow.
I think Apple Watches or all kinds of smart watches and smart devices are usually pretty accurate, but they're not perfect. Any kind of irregularity in your heartbeat, sometimes they'll call that atrial fibrillation when it's not. There are extra beats that come from the top or the bottom of the heart that we call PACs or PVCs, and that creates irregularity. In younger people, sometimes the normal heartbeat can be a little irregular also.
But if you do have a device like that has told you that a couple of times, you need to check it out.
Absolutely. And when we see people, we see those are wrong sometimes, and sometimes overestimates heart rates, underestimates heart rates, but they come in handy. I think the incidence of atrial fibrillation, they say, is climbing, and instead of 5-6 million a year, I think by 2030 they estimate 12 million in the U.S. So part of that is probably because we're identifying a lot more of it with
all these devices.
I think so.
All right, Ashley, do you have any more questions? All right, well, thank you so very much for calling. And finally, ablation. Who gets that? We've got about 1 minute left.
Ablations, I think people that have lots of symptoms. There's people that have atrial fibrillation that do quite well. Some people that have atrial fibrillation that feel terrible when they have it. Or people that have refractory atrial fibrillation. You're on several medicines, and those are the people that need an ablation, need to be sent to an electrophysiologist.
All right, and so for our viewers right now who've been listening and they're thinking, I need to call this guy, I need to go in and see him, tell everybody how they can get in touch with you and where they can find you.
We're at Piermont Cardiology. There's 9 of us there. 212-3858, I believe, is the number, and or through primary care physician, but people can call directly as well.
Okay, and Piermont Cardiology is located where? Because we have viewers in 4 states.
It is in the Medical Arts Building at near the corner of Burt Coons and Uri Drive, near Willis Knighton Piermont Hospital. It's right across the little bridge.
Here in Shreveport. So,
yes.
All right. Well, thank you to all of you for joining us. And that was a great Healthline 3, and we hope you have a very good day.